Go ahead, Ronan.
Good morning, everybody, and good day or good evening to people right across the world. Welcome to this panel session on data and response to COVID-19. My name is Ronan Lyons. I'm Professor of Public Health at Swansea University, and I lead the Health Data Research UK Improving Public Health theme. So at today's session, we've got, as I said, 3 speakers. I will introduce each of them and then they will speak for 10 minutes. And after that, then we have a panel discussion and plenty of time to discuss the issues. So if I start off, first of all, the first of our speakers is Professor Yik-Ying, commonly known as YY. He's the second dean of the Saw C. Hock School of Public Health at the National University of Singapore. Trained as a mathematician at Imperial College, he completed his MSc and PhD and DPhil at Oxford in statistics genetics. YY then returned to Singapore in 2010 after working for 4 years as a lecturer in Oxford and concurrently research at the Wellcome Trust Centre for Human Genetics. Prior to his deanship, he was the founding director of the Centre for Health Services and Policy Research and also director for the Centre for Infectious Disease Epidemiology and Research. He's presently a member of the Council of Scientists for the International Human Frontiers Science Programme, as well as a member governing board, member of the Regional Centre for Tropical Medicine and Public Health Network for Southeast Asia. So YY, if you could start your presentation, please.
Thank you very much, Ronan. And I hope all of you could see the screen. So I'd like to start off by thanking the organizers for the invitation and to speak a little bit about some of the use of data in Singapore, both for COVID and outside COVID. And I thought it would be useful to first start off with a description of our COVID efforts. And Singapore was one of the first few countries to be around the world to be affected by COVID. We saw our first case in middle of January. And very rapidly, Singapore earned a positive reputation from colleagues around the world in global health, public health, as well as our colleagues at the World Health Organization. But very rapidly, within a period of less than 2 months afterwards, Singapore moved from a gold standard to become a cautionary tale. So I wouldn't spend too much time talking about the cautionary tale, but I will spend a little bit of time working on what actually earned Singapore that definition of gold standard in the first instance. And it has continued to keep Singapore in a relatively safe condition from COVID-19. And it's really around our use of data, particularly in linkaging cases or what we call contact tracing. So from the very beginning, contact tracing actually was very much part of a national response. But I have to say that contact tracing within a country that has 6 million people and much smaller geographical expanse is a lot easier. So we do benefit from that. But that contact tracing allowed us to really establish where and who infected whom. And from those efforts, we were able to find out which are the settings that are most conducive for spread of COVID-19. And this contact tracing actually moved beyond just local efforts, but also looking at where importation came from and how it infected people within the Singapore in secondary, tertiary chains of transmission. And unfortunately, some of this transmission subsequently entered the migrant worker dormitories. And even within the migrant worker dormitories, the ability to identify who infected whom and where and when has been tremendously important in managing a situation like COVID-19. We were able to construct maps or linkages that links between clusters of infection in different parts of Singapore. So that has been very much center of our COVID efforts at the moment. But I thought I would talk a little bit beyond COVID-19 as well, because quite a lot of outbreak surveillance to policy evaluation actually rely on the ability to link the right kinds of data and to analyze this data properly. And I will actually talk about also a real-time outbreak that happened in July of 2015. And please take note of this date, July of 2015, because that was when Singapore's Ministry of Health realized that there is an outbreak happening in the community amongst people who like to eat particular kind of raw fish. It's quite typical in East Asian culture. But actually, when we started to look at the data from epidemiological surveillance, what we realized was that when we found out that there was clear resolute signal in the hospital of an outbreak happening in July, when we went back and started looking at laboratory data that from lab tests that were happening in public hospitals, and we started looking at the signals, we realized very quickly that actually the inference inferred that the outbreak could have started as early as October of the year before. And if we have a way of collating this data in a national framework, we would have caught the outbreak as early as 5 months before, in February, rather than in July. And that actually led to certain changes in the way we manage infectious disease lab data. Because from this episode, the Ministry of Health now routinely collates laboratory reports in a weekly fashion, and there is a real-time outlier engine that works on data inference behind the scene that is automatically churning out all these reports to see, is there any signal of an outbreak happening in Singapore right now? I would also talk about another example, which is really around policy evaluation, which is where if you have the ability to perform real-time surveillance of outbreak, not just COVID-19, and I'm going to use Zika that happened in Singapore in 2016 of August. There were questions around how quickly would the outbreak grow, how widely dispersed would the transmission be, and just like COVID-19, who infected whom, and where, and when. Those are very important questions in an outbreak surveillance. And this is where, again, having the right kind of data from an epidemiological framework, or from a real-time collection framework with the right kind of data, analytics, artificial intelligence engine, neural networks engines, we are able to establish are some of the control mechanism working in Singapore against Zika. And the final example is really around looking at a slow burning infection against outbreak surveillance, but in this particular instance, looking at multi-drug resistant TB that was spreading in a gaming center. This is where people come together to play computer games, spend a lot of time, typically foregoing good nutrition and good sleep. So in 2012, there was an outbreak in a gaming center. In 2016, there is another outbreak of multi-drug resistant TB in Singapore, but this time around, it was in a housing block estate. And people who are working in infectious disease would say that for TB, it is a slow burning infection. I could have been exposed and infected perhaps 10, 20 years ago, but I could only manifest the infection later on in life. And this is where having the ability to perform genetic surveillance becomes extremely important and useful in establishing the infection map. And in this particular instance, we actually saw that the link between the 2016 outbreak, it's driven by exposure to someone 2012. And even that cluster in 2012 was introduced by an index infection that entered Singapore in 2008. And this is where having that genomic surveillance now has changed the way Singapore manage an infectious disease such as tuberculosis. So this is just very quick points that I wanted to raise. And in conclusion, 3 take-home messages. Contact tracing for COVID-19 for any infectious diseases remain one of the most powerful way to manage an infection, because you very rapidly identify who is infected and you could quarantine and isolate those exposed people. Not just for COVID-19, it's the same for many fast-burning infections. The kind of data, analytics, the use of methodological inference, it's very powerful when we could couple it for real-time surveillance and management of an outbreak. And more importantly, the ability to actually respond during a public health crisis from the data perspective has to be something that a country, a society built up during peacetime and not during a crisis time like COVID-19. And with that, thank you very much. Over back to you, Chair Ronan.
Oh, Thank you very much, YY. That was fascinating, and a good lesson to everybody, how well that system works, and the ability to contact or trace people, particularly across the country, is very impressive. So rather, I think, than having questions at this point in time, I think probably the best way is for us to go and actually have each of the presenters, and then at the end we'll accept questions from the audience. So I'm now going to just introduce our second speaker, who's a Professor Jodie McVernon. She's a public health physician and epidemiologist with extensive expertise in clinical vaccine trials, epidemiological studies, and mathematical models of infectious disease. She gained in Oxford, London, and Melbourne. And for the past 15 years, she's been building capacity infectious disease modeling in Australia for immunization and pandemic preparedness policies. She's led nationally distributed networks of modelers performing responses to the 2009 H1N1 influenza pandemic and the current COVID-19 pandemic. So Jodie.
Thanks very much, Ronan, and I will now share my screen. Okay, so again, thank you for the opportunity to present today. I'm coming in with a different perspective and with a different angle on data, and I guess some novel forms of data that have been really influential in understanding COVID-19, its behaviour, and the impact of interventions for its control. So I think the thing that struck me most about this pandemic right back in January, when WHO started convening networks of modelers, was the quality and nature of the data we were looking at. This was a time at which there was still very little known about COVID. Diagnostic PCRs were starting to be rolled out. It was clear there was case under ascertainment, and most of the data that we were all reviewing on a weekly basis on phone calls that for me were at midnight were scraped media reports. So we were all following everything we could read about this pathogen at a time when data systems were still catching up. And in fact, one of the most influential early pieces of modelling that was done came from Imperial College, looking, and there were other corresponding analyses from similar groups, looking at the number of cases of COVID that had been exported from Wuhan in the early phases of the epidemic, building on established network models of international air travel that basically could tell us how many people were flying between different parts of the world, and using that basic number of journeys or number of potential exports to infer that from 3 exported cases globally at a point in time, there were probably at least 1,000 cases in Wuhan already at a time when, say, 44 had been reported. So we started to, from a very early point in time, see the use of different forms of data to help make sense of and interpret what was still sparse and rapidly emerging information at a time when public health response and the clinical response in Wuhan were acutely under pressure with first emergence of this disease. And then again, models were used to make sense of early insights that came from transmission chains of infection. So here is another influential paper from the Hong Kong group, looking at here on the graph, these green bars represent the contact time between individuals, or exposure windows between individuals who were primary and secondary cases of COVID-19, with the red, the onset date of the primary, and the blue, the onset date of the secondary. And from these early line listed data, which were able to be analysed by the Hong Kong team, inferring some key epidemiologic indicators that gave us initial insights into the likely infectiousness and spread of this pathogen. And these sorts of analyses have been repeated and refined over time, but these still are a very nice example of some of these key parameters that determine the rate and extent of transmission. So the serial interval between infections, the density of new infections occurring or being transferred in relation to the days after symptom onset. And so this early indication that a proportion of infections were transmitted before the onset of symptoms in the index case, which has been a critical feature of this disease and made it so challenging to control. And then again, the days from infection to symptom onset with a long tail being critical for that determination of the duration of the quarantine period. You know, what is our maximum reasonable time frame within which we believe that we would capture all cases that might present having been acquired within the interval. So these early epidemic parameters allowed all of the rest of us in countries where nothing had happened yet to try to think about and infer what the likely rate and extent of epidemic growth might be to start preparing. This is one example of some of the work that we did in Australia. So this model by Rob Moss and colleagues built on earlier models that we had developed that were examining clinical pathways of care, initially in relation to pandemic influenza, to think about how the use of antivirals might modify the severity of disease experience. But in this case, thinking about the ability of individuals to access care along a care pathway, all the way from primary care through emergency departments and then into hospital wards and intensive care. And this model is actually configured on the basic features of the Australian healthcare system. It has relevant bed capacities configured on available data, but also thought about the importance of bringing in alternative treatment pathways. And so using these early epidemic parameters of growth, we, with other modelers around the world, horrified our governments by saying that this epidemic, if mitigated, and these are the first set of scenarios here, given the uncertainty that we had in the time, we ran many thousands of simulations and produced epidemic scenarios that encapsulated that uncertainty from 5th to 95th percentiles here with a median in the middle, basically saying this was going to be big, this was going to be long, this was going to be painful. And with others at Imperial and in other groups, that, that if we did not mitigate this epidemic, that it would vastly exceed our intensive care bed capacity. And we were also interested in all the steps along the way, that actually this would completely overwhelm the hospital system. And this certainly was what was being seen as this epidemic grew around the world. And so we ran a number of additional scenarios, and this was very early preparedness work. It was really, these weren't predictions, they were scenario analyses. They were thinking about, within this model, we had the capacity to implement quarantine and isolation. So what would an active public health response be able to do in terms of constraining an epidemic? And when we, ran those figures, we found that even with those constraints, we would still likely exceed available capacity. And so that was then the case for augmenting those public health responses with social measures. And obviously, from back in February, we were all wondering how we would ever do these sorts of things. But as we saw lockdowns rolled out around the world, these sorts of non-pharmaceutical interventions became a key part of our strategy. So the purpose of the model was not to say this is how many ICU beds we need. The purpose of the model was to say, based on the early epidemic characteristics, we are going to need a tripartite response with enhanced clinical preparedness, strengthening of public health, and social measures to constrain the spread of infection. So it was part of establishing that early set of measures and goals to suppress transmission. Over time, I and others have worked with Australian government to advise on the pandemic response, and one of the key elements of that has been situational assessment. And again, situational assessment looks at epidemic growth, it looks at case numbers, it tries to estimate the rate of growth in terms of the reproductive number, which we call the effective reproductive number at a point in the epidemic when it is experiencing certain constraints. But here in Australia, we have been very fortunate that our early measures actually led to substantive mitigation and in fact, effective elimination of the pathogen almost around the country. And in fact, it's only in my home state of Victoria that we've had a substantive second wave that again now has been returned to control. But the key parameters that we were estimating for government were where there were cases, what the effective reproduction number was. But in other states and territories where elimination had been achieved, the bigger interest was, if a case is imported, what is the propensity for that epidemic to take off? And so the indicators that we were measuring were actually not just about how are the cases that we see growing, but what is the potential out there in the community for spread? And this was based on quantitation of population behaviours in terms of mobility, so what we called macro distancing, the proportion of time people were spending at home, the distances people were travelling, but also micro distancing. So based on survey data, what was compliance with recommended distancing behaviours and hand washing and face mask wearing and so on. And so these were brought together or have been brought together every week in situational assessment reports to think about where states and territories are up to, given the level of their controls and compliance with those, but also what's happening with the cases that are actively transmitting in that jurisdiction. And so with that, these methods have been developed by collaborators around the country, including Nick Golding in WA, who's particularly strong in mobility modelling, to think about the average local transmission potential of active cases, taking that social and environmental milieu into account. And again, just highlighting the importance of non-traditional data. This is not health data, but Facebook, through its users, Facebook's Data for Good program, that's right, has made available to academic users many of its mobility and movement indicators, and many of you will be familiar with the Google mobility indicators. And these have basically been very important for many of us in understanding how measures that have been applied at the population level have actually impacted on movement and mixing. This particular one is the staying put indicator. And from left to right, this is moving through Victoria over the past year, where in red we've had lockdown periods here beginning and becoming more intensified over this stage 4 period. The two different colours represent metropolitan Melbourne and regional Victoria, which have been on different policy settings, particularly in this latter phase. And you can see that from early beginnings in March, as restrictions are imposed, a greater proportion of people are staying put in association with lockdown. We see that activity is returning more to normal, and then a second set of lockdowns, and then this disconnect between city and country. So these have been really important indicators to see what we're actually doing. So my reflections on data and modelling in the year have been that media reports, crowdsourcing and non-traditional forms of data have been essential, that modelling of approaches have been useful to estimate key epidemic parameters, to understand disease impacts, that incorporation of behavioural and mobility data has been critical to interpreting epidemics, and that further exploration and linkage of health and clinical data will be needed as we try to understand further impacts and burden and consequences of this disease. And there have been many people involved in this work around the country. Thank you very much.
So thank you very much, Jodie. That was a lovely presentation. I'm sure that there'll be lots of questions. But without delaying more, I'm just going to introduce our final speaker, and then we can have the discussion. So our final speaker is Professor Daniel Prieto-Alhambra. He's Professor of Pharmaco and Device Epidemiology, Centre for Statistics and Medicine, NDOMS, University of Oxford. His extensive expertise in the use of real-world data from electronic medical records and health claims. Professor Prieto-Alhambra is the research coordinator for the European EDEN network and has collaborated with researchers from all over the world in the Odyssey community to rally against the COVID-19 pandemic. So Daniel, can we have your presentation, please?
Thank you so much. Let me share my screen very quickly. Hopefully you can see my presentation now.
Yep.
Okay, well, thank you. I'm delighted to be here. Good afternoon, everyone in the eastern side of the world, and good morning if there's any early birds from the UK or Europe joining in. I'm going to be talking about open science and real-world data to characterize COVID-19. Just to clarify, when I talk about real-world data, what I mean is basically routine health data collected from electronic medical records and health claims from all over the world. These are the three topics I will cover. I will start by giving a pledge for open science. I will then cover the EDEN Odyssey COVID-19 collaboration, and I will finally talk about unraveling a new condition, unraveling COVID-19 with real-world data, and how the devil, of course, is in the detail. So to start with a pledge for open science, I think we have all learned during these last few months that, of course, data can save lives if given to the right people and in the right hands and with the right parameters, but data can also be harmful. And we've learned this very painfully through the Surgisphere scandal. There is also in the past a lot of evidence that data, when left to its own devices and not handled appropriately, can lead to lots of trouble. And this is an example of a systematic review of almost 12,000 papers of observational research, where you can see very strong evidence of p-hacking with all these dots. Each dot is a paper or an estimate clustering around the p-value of 0.05 threshold, with very few just above the threshold, showing that there is very bad practice and very poor practice in the publication of results from observational data, unfortunately. So how are we going to fix this? We believe that open science can help us fix this problem by making all our analytics and artifacts available. We believe that we have to share, and we do share in the Odyssey and Eden communities, all our harmonization results, all our data quality dashboard and results. All our study protocols are pre-specified and uploaded or registered. All our analytical packages are made available in some sort of repository, study diagnostics, and finally, we propose that we do exact full reporting of all the analysis conducted in an interactive platform, just to account for everything that has been done and cannot be reported in the usual manuscripts. We believe that by doing so, we are encouraging others to do the same, and we believe that this level of transparency will lead to better reproducibility, interpretability, and trust. So this is what we did for the COVID-19 example. This is just one of the few studies that we did. This is a study looking at the safety of hydroxychloroquine, where we created a full protocol and posted it in a public registry. We created all our cohort definitions and put them again in the open so everybody can replicate the study. We shared all our analytical code in a GitHub repository. We posted our results in a preprint as soon as we had them available. And finally, all the results from the study are available in this link that you can see here, which is an interactive web application. I'm now going to speak about the specific work that Eden and Odyssey have been doing together to help the response to the COVID-19 pandemic. Odyssey is an international data sciences and informatics open science network where we have colleagues contributing from all over the world. And for this particular study and for this particular area of research, we have had loads of collaborations across North America, Europe, and Asia. We have now data for over 4.5 million people tested for SARS-CoV-2, more than 1.2 million tested positive or diagnosed with the disease, and almost 250,000 people hospitalized with COVID-19. And this all started with what we called a hackathon or a studyathon that we held in late March 2020 this year. The original plan was to host a meeting with colleagues from all over the world to discuss access to data, analytical tools, and all the things that we do in Odyssey and Eden. We had more than 300 people registered for this meeting that was going to happen in Oxford to talk science, to learn, but unfortunately we had to cancel that meeting and we moved to this online platform instead, where we had 4 days of collaboration with 350 people from 30 countries, thousands of messages, and we ended up doing 3 things that had never been done before in only 4 days. We created the first large-scale characterization of COVID-19 patients admitted to hospital in Europe, US, and Asia that I will share in a second. We created a first prediction model that was externally validated internationally on who was likely to suffer severe forms of COVID-19. And we completed the largest study ever conducted on the safety of hydroxychloroquine. And this hasn't ended. That was only the kickoff of a very long, unfortunately long collaboration that we've had since then. And we're still now harmonizing data from more than 25 colleagues from around Europe, very different countries, very different environments, including data from France, the UK, or Istanbul, just to mention 3 of them. I'm now going to be sharing some results of the research we've done on unraveling COVID-19 in real-world data. The ideal definition for a new disease is a definition that has to be clinically relevant or clinically sensible. It has to be actionable and interoperable for different types of data around the world, transportable if you're working in a network like ours, sensitive and specific. And of course, it has to be possible, which is difficult if you want to tick all the above. In our case, what we ended doing was a number of operational definitions. We looked for people who tested positive in a PCR for SARS-CoV-2 as one potential definition of the infection. We looked at clinically diagnosed with COVID-19, and this is because in many parts of the world, including Southern Europe and also the UK, many people did not get tested because they just didn't have enough severe enough disease. We looked at people hospitalized with a diagnosis of COVID-19. We looked at people admitted in ICU with a diagnosis of COVID-19, and of course, we could look at mortality with COVID-19. And there are many other potential definitions that could be used. So this is what we did. We had our largest cohort of more than 4 million people tested for the virus. A subgroup of those would be people tested positive, so therefore infected with COVID-19 or with SARS-CoV-2. We then had a subgroup of people that some of them were tested, some of them weren't, that had a clinical diagnosis or a positive test. We then had people hospitalized with a positive test, people hospitalized with a positive test or at least a diagnosis. And finally, we also had people who were admitted in intensive services. And this is what the data looks like in numbers. We had almost 4.5 million. We have so far almost 4.5 million people tested with COVID-19. And 8% of those tested positive, and then a much smaller number hospitalized with a test positive. If one is happy to go with a clinical diagnosis, which means that you don't have data on tests, the numbers jump up dramatically, and we have much bigger numbers, as you can see here. So different phenotypes will provide different levels of confidence and reflect different levels of severity of the disease. They will accommodate different types of data and different geographical areas of the world. And very importantly, things will and are already changing over time with increasing test capacity, different types of tests, and different patterns of community transmission. And now I will finish by sharing very quickly some the first results that we put in the public in early April that are now published in Nature Communications. This is an exercise where we deeply phenotyped 34,000 individuals admitted with COVID-19 in North America, Asia, and Europe. Again, sharing all our study protocols, all our phenotype definitions, a manuscript posted in medRxiv, and all our analysis available in a web application. We had mostly data from Europe, but also some data from Asia and North America. We looked at people who had had influenza in the previous years as a control or a benchmark, and we extracted from 5,000 to 11,000 features for each of the people that were phenotyped here. And you can see here the results. These plots here show basically for each of the data sources, each dot is a condition or a medicine, with the y-axis being the prevalence of use, and then what you have in the top bar is more common in COVID-19. The bottom bar is more common in the flu, and you can see how COVID and flu are very different conditions, with people admitted with COVID being generally healthier, with less history of medications use, with the only exceptions being obesity, diabetes, and osteoarthritis, which were much more common in people admitted with COVID-19 than in people admitted with the flu. And this is the interactive application that I invite you to visit and to look at the results we obtained. The summary to date, we have 32 international papers in preprint, 4 papers published to date, and many others under review. And we continue to work together with an amazing group of people from all over the world who are contributing to the response to this pandemic. Thank you.
Oh, thank you very much, Daniel. That was a very enjoyable presentation. So we've had 3 presentations at this point in time, quite different on different aspects, but all fascinating. And many of them have a number of commonalities. I think some of the things that I particularly point out to is the use of novel data sources that we haven't previously been used to using, that are needed in a hurry. Standardization across countries, and they effectively what becomes multidisciplinary team science in order to produce results on a very rapid progress, really. And one of the aspects about this, I think, is worth considering is this open science aspect, which Daniel has mentioned there. There are very many different collaborations around the world. And if I was looking at, even within the UK, people looking at predictive models for COVID, there's about 4 or 5 different groups who are effectively competing to produce things in the journals, and that's been repeated everywhere. And so one thing actually is to think about at some point in time, how can we have a sort of even broader engaged multidisciplinary team science Or does that actually challenge the whole competitive nature of academic research? But whilst we're just pondering on things like that, I'm just going to come and look and see what people have put up on the chat questions. So there's a number of questions here. I think the first one I see is from David Preen to YY. YY, can you see that chat? Or
Actually, I have a blank chat, so I don't see any of the questions, unfortunately.
okay, well, let me read out the question. Are there any plans to extend the linkages of the COVID and pathology data to other health services data, for example, ED, hospital, etc., going forward, and to examine longer term impacts on patients infected with the broader health system?
Right, so thanks very much for reading out the question, Ronan. So the answer is yes, because in Singapore, we have actually made a concrete effort to work towards consolidating our medical databases such that we can provide real-time dashboard for whether it is at the ministry level or whether it is at the subcluster within the health systems level. So Singapore's healthcare system is divided into 3 clusters, and we are working towards a frame that we could look at a dashboard within each of the clusters to see what is the extent of data of availability in bed space, in waiting times, in availability across different services, such that you could actually funnel people according to availability. This is already working at the cluster level. So hospitals are able to say that within hospital A, physiotherapy services are full, but hospital B, which is just nearby, actually has it available. So you could actually shunt some of the patients who need physiotherapy time over to hospital B. And the aspiration is to work towards a unified version of this dashboarding at the country level rather than at the cluster level. COVID-19 has actually helped because we have been able to have a unified vision or unified reporting of the available ED space, ICU spaces, and all the necessary resources that are needed to look after patients. So we were able to move patients very rapidly between hospitals according to availability. And that is how we managed to keep the hospital resources in check and not having a situation where it was overwhelmed and people are running out of beds or ventilators when they need them. Over back to you, Ronan.
Yeah, thank you very much. And I think if I could bring in Jodie, because in your presentation, you mentioned situational reports as well for Australian and state governments.
Yeah,
Could
so
you just say a little bit more about that?
Yeah, so similarly, we've had the sort of dashboard type of arrangements that YY refers to, particularly in terms of ICU capacity, and at state level, jurisdictions would report, in a more granular way, looking at the regions that were particularly affected. We've tended to find that particular areas of major cities have had, problems with localized spread. And so thinking about resources and services there, but I mean, overall, we've been very fortunate that we've not exceeded that capacity. I think some of the ongoing questions, and I know these are being addressed in other places as well, is really trying to understand more about, as we follow these patients through the system, as we see what happens next. And obviously long COVID is of great concern to all of us, that particularly the awareness that many of the people who will experience this did not necessarily have a severe initial course. And so we've been talking further with colleagues both in the hospitals, but also in primary care, about how we understand that whole ecosystem of care, about what happened with the first episode and what is happening since, and try to understand more of the patient journey, I guess, over that whole course of particularly prolonged illness, to know what to anticipate in the future.
Yeah, no, and I think that was particularly the point that David Preen was making, was this aspect of the ability to track people longitudinally and understand the effects on them, and then also understand the effectiveness or not of the various intervention strategies that are being tested around the world. And just knowing how easy that is to do in different jurisdictions. I mean, where I work in Wales, this is something we do automatically. We have a linkage system. We can link all the COVID pathology results to general practice and hospital and multiple other data sets, and are involved in, you know, lots of different studies trying to understand what that impact is. That I think is very useful, because the interventions, or the policy interventions, also are very different in different parts of the country and right across the world. The degree to which people adhere to the advice or not are also very different. And so working out which are the most effective interventions on the non-pharmaceutical interventions is really an important one. And then it's also, there's an awful lot of work, I think, has been done on hospitalized patients. And I think, as you rightly say, the issue of long COVID, to what extent that affects non-hospitalized patients, is a really important issue. I mean, I was looking at the other day, I know in our system, only 11% of patients who've tested positive have had a hospital admission. So some 90% of people are out there in the community, and much less is known about them. And so it's our ability to actually answer some of those questions. So if I brought in Daniel, because his Eden and Odyssey network would be interesting as to what you're doing in this space.
Yeah, thank you, Warren. So there's a lot of interest, of course, on the not admitted patients, and indeed the easiest to do is always to look at the data that has been collected during a hospital admission, and that's most of the data we got from China in the first few weeks of this pandemic came from hospitalized patients, and then from Italy, even sometimes only patients admitted to ICU, so the most severe spectrum of the disease. We have done a lot more work in the last few weeks looking at patients who are not admitted, and also looking at transition modeling, looking at how many people will transition from an outpatient diagnosis to a hospital admission, to an ICU admission, and even to death. So that's the other bit of information I believe we still need to gather. Eden and Odyssey are rallying together to do this at an international level, and that has a number of strengths, but also a number of challenges, including, of course, the way different healthcare systems work around the world. But that is proving a fascinating exercise, as you can imagine.
Yes, and if I could just, I think, follow up, Daniel, because I think the next question it comes to you as well, and this is one from Jason Burke, as who was asked, was there no appetite or capacity for collaboration from any African, South American, or Australasian partners? Or was it purely opt-in and those collaborators were whoever joined? So I think that was just focused about how that group works. And I think we appreciate the challenge is to actually only a minority of people in each country, or perhaps even in a single university, are involved in some of the networks. And then how do you expand that to actually be more inclusive?
Well, I'm actually quite proud of the inclusiveness of the Odyssey network. Odyssey is basically an open science collaborative where anybody can join just by logging to one of our forums and saying, hey, I'm here, I have data, can we collaborate? That has happened indeed. So if you look at that first paper that I posted, that was initiated by of course, the champions that have, a lot of data and a lot of knowledge of data around the world. But since then, the amount of data we have collated has increased dramatically. And also not only data contributors, but also people that have knowledge that we didn't have in the collaboration previously. People who can model data, people who can do different types of analysis that we didn't have initially have joined the collaboration. We do have people now mapping data from other parts of the world. We need to go through that harmonization aspect. And as I said earlier, there is, I think, a very large risk in the use of data that has not been previously curated. Nobody knows what happened with the Sargisphere dataset, whether it's true data or not, but that clearly is data that has no provenance and that we cannot really assess and look at the quality of. And that is what we really have to prevent in this pandemic. So the kind of speed should not compete with quality.
You know, I think it's really good to hear that, Daniel, and it's probably that not everybody is aware of how open Odyssey Eden is, but at least it gives you an opportunity with a group of people here today to sort of show that anybody can join that. Let me just have a look now at any further questions. Yeah, I think Lauren Staples just agrees that there's a very open, collaborative, multidisciplinary approach. And I think that's the case. So if I'm just going to think about now whether if I come back to the presenters and say, what do you think your next big challenge is now that you've got so far? So why I see you with your hand up?
Thanks very much, Ronan. I actually do see that there is a need for data scientists and epidemiologists to actually consider very carefully about what is our role in a time of COVID-19. And that role goes way beyond just publishing good papers, but at the same time thinking about how our knowledge can help to influence some of the policies that are being taken in our countries. Clearly, we have the ability to analyze some of this data to provide rather unique insights. And the question is whether these unique insights are made in a manner that policymakers actually can receive guidance from scientists and then to develop some of the policies according to the evidence. Jodie gave a very good presentation around the use of models. And in a country like Singapore, we benefit from having technocrats as politicians. And what that meant was that our politicians, as well as policymakers in civil service, were eagerly asking scientists, modelers for outcomes. Should we close schools? Should we shut down the transportation network? Should we ban flights coming in from China, from South Korea, from Iran during the early days? And all of these insights were actually provided to the policymakers from modelers, very much like what Jodie mentioned. And based on the modeling results, that's where some of the policies were taken. For example, in Singapore, we decided not to close schools until much later, where there was a systematic lockdown. But the schools were closed at the latest and were opened the earliest, based on some of the science from modeling. And I see that this conversation between scientists and policymakers, it's one that is very important and underpins a lot of this multi-sectorial discussions that we have been having. Over back to you, Ronan.
Yeah, thank you very much for that. I'll just ask Jodie to come in and then Daniel.
Yeah, so look, thanks, Wawa, and I agree. I think this interface between expertise and policy, I think, on the background of the role of expertise in public life, it certainly had a revival this year. And while at times that's put it in a warring position, and we've seen the rise of the weaponized expert, which has sometimes been challenging, it really has been a place where we've seen governments that have very effectively used evidence in policy. For me, the big challenge moving forward is to understand heterogeneity. So while there's great benefit in bringing together data across contexts and settings, the big mysteries of COVID, from my perspective, are why we've seen such disparate experiences in different parts of the world. So, for example, we're working, funded by our Department of Foreign Affairs and Trade, to help support countries in the Pacific. And while many of those successfully kept COVID out through border measures, those that have had importations have tended to have stuttering and rather limp epidemics that really have not taken off in the way that we'd expect, even in populations with underlying risk determinants. And while, in different parts of the world, we've seen surprising things, settlements where outbreaks haven't been catastrophic, and just the things about this that we don't understand. So I'm really interested to see how we can bring together these disparate experiences and better understand, why this has been an epidemic that's largely wreaked havoc in high income countries and obviously other parts of the world as well, not minimizing that. But, what about it is the population characteristics or the climate or just other features of our society or the way we live. We're seeing so many social and economic determinants in here. Can we use our data better? Can we understand how to integrate human behavior better to really appreciate both disease and its control? So that's my particular interest.
Yeah, no, I think those are really, really interesting questions. I mean, it's fascinating the way it has gone with the expertise, so that we've effectively had modelers initially predicting what would happen and estimating the likely impact of different intervention strategies, which have been applied or not, depending on which your jurisdiction is in. And now I think the challenge is, having gone down that route, is to actually work out which ones have worked and which ones haven't worked, and what are the determining factors of those. As you say, there's huge variation of that across the world. If I'm going to bring in Daniel now into this part.
Yeah, I think that is indeed one of the key challenges that we have ahead of us in the coming few weeks or months, linking or joining the dots between the kind of aggregated data that one can get from, government decisions, document recommendations, all the policy data, and the initial models and the data that we are collecting from routine health data sources to see how each different intervention has had an impact or not on the transmission and the severity of this pandemic in different parts of the world. I think that is where we have to put a lot of effort in the coming few times. And then, of course, as we see new technologies making it to human beings, like vaccines and new testing systems, we will have to, of course, incorporate that in our toolbox, and also see how we evaluate those over time.
Yes, indeed. Yeah, vaccine effectiveness in real world situations is, I think, going to be a serious challenge, which hopefully will start happening soon. Or certainly in the first 6 months of next year. I think there should be quite a lot of data flowing on that. Just wondering then about the potential for more international collaborations on some of these areas. One thing that strikes me is that Odyssey and Eden are fantastic initiatives, but there is some limitation on the type of data that can be standardized under those models. And also, you tend to essentially collect information on individuals longitudinally, but then there's also this need to nest individuals in other groupings, so within households or healthcare settings or school clusters, to be able to answer those questions. And I know that's something that we do routinely in our system. We're fortunate to be able to do that. But I'm interested to what extent that's possible in other places. So, yeah, Daniel?
Yeah, no, just to mention, so Odyssey and Eden share a same common data model. We use OMOP, and I still remember when we had the first conversations about what common data model Europe should be using, and this was a kind of lengthy conversation where we, had discussions with people from all over the world, but including many countries in Europe. And the reason we went for OMOP, there are two main reasons. One is that OMOP is an open CDM which can be modified over time to incorporate things that might be relevant. So for instance, with the COVID pandemic, we of course had to incorporate very quickly new tests and new diagnostic codes that had not existed previously in the common data model. And that was something we managed to do within days. And that is not something that you see, generally speaking, in other types of common data models that are not moved by a large community like Odyssey. The second reason we went for OMOP is that it has the ability to preserve the source data together with the mapped data, so that that enables basically modeling of things that can be done only in certain countries. So for instance, when you want to look at transition modeling, so from outpatient to inpatient settings, that can only be done in countries where you have a universal healthcare system, where GPs are gatekeepers to that system. So you are basically stuck with data from Spain, the UK, Italy, a few countries in Europe, and potentially others around the world, but you need to have the ability to map the setting where things happen in those places. And that is something we can enable in OMOP. So you will only be using a subset of the datasets that you have available, but that is still possible within this common data model, and it's not possible with many others.
Yeah, I think that's very, very helpful. Those sort of things, they're possible, Jodie, in Australia, in Victoria? I do know a bit because I spend a bit of time there each year.
So around the country, we have differing enabling legislation around data linkage. So we all just pray that we live in Western Australia. But so yes, we have variable challenges. I think part of our national challenge is that healthcare is largely devolved to states and territories, which also have their own information systems. So within the level of a state and territory, often more can be linked, depending on how that system is set up. But definitely the need for better unified national systems for this type of response have been long called for and are certainly gaining more traction in this situation. So yes, having a distributed and partially devolved system is part of our challenge there.
Yes, and what was very impressive was your ability to track infection right across the population, and including in those workers' hostels. So I imagine that your ability then to look at how infection changes by the location of individuals and the clusters must be very, very good.
Yes, and in fact, there has been quite a lot of work, both epidemiological as well as modeling, to look at what were the drivers of transmission, what were the drivers of transmission in the different dormitory types. Because we have in Singapore around 350,000 migrant workers living in densely built dormitories. Some dormitories have en-suite facilities, some dormitories have shared facilities, communal bathroom and communal shower toilet facilities. And there was actually a very deep study of the different characteristics of spread, of transmission, including both the speed as well as the degree, based against some of the background. Is it having an ensuite toilet that actually helps to minimize the speed of spread and so on? So actually all of this, the data were collected, and we actually do have real-time data in terms of today, that bed number in this particular room reported sick and was found to have COVID, tomorrow someone else. So we were able to track this very much longitudinally as well. And that gave us quite important insights into the design of future dormitories for migrant workers. In fact, that's a project that has brought together economists, public health practitioners, infectious disease experts, as well as modelers. So yes, having that degree of data fidelity does help one learn more about the transmission dynamics, and in doing so, identify how do we protect, what we build the environment to protect.
Thank you very much. I'm just looking at the time here, and I've my little cue to wrap up before we go. So I'd just like to thank all three presenters. I thought they were absolutely superb, quite different presentations on different aspects of COVID. Lots of wonderful insights, and then also this fantastic opportunity to collaborate more internationally and join open standards networks. I thought it was superb. I enjoyed it immensely, learned lots, and I'm sure everybody else who's listening have done so also. So just to say thank you all, and hopefully you enjoy the rest of the conference.
Thank you.
And then we'll be chopped out in a second.